And it's my pleasure to introduce our guest tonight. We have Dr. Tatalia here, who's a clinician scientist at the University Health Network and University of Toronto. She maintains a cognitive behavioral clinic within the UHN Memory Clinic, where she sees patients with neurodegenerative diseases, those with multiple concussions who are at risk of developing a neurodegenerative disease. She holds the Marion and Gerald Soloway Chair in Brain Injury and Concussion Research. She uses a multimodal approach to better diagnose and understand the pathological substrates that cause cognitive, behavioral, and motor dysfunction, with the goal of developing biomarkers to bring precision medicine and targeted early treatments to her patients. So hopefully you got that, because I keep getting told that my internet's unstable. So I'm going to turn it over and welcome.
Thank you for the kind intro, and great to see all these people. So I'm looking forward to your questions. So my name is Carmela Tartaglia, and as you heard, I'm a clinician scientist. So I see patients with neurodegenerative disease, and I'm actually very excited about the time we're in right now, because for the first time, we can actually really feel that things are changing and that there are breakthroughs that are here and even more on the horizon. So these are my disclosures. We're going to talk about dementia, what it is, what it means. We'll talk about treatment and some treatment updates. So I don't think I need to belabor that dementia is a very, very, very common problem. Age is the biggest risk factor for dementia, and you may or may not know that the fastest growing group of people in our society are those above the age of 60. And so in 2020, the number of people over the age of 60 and equal to 60 outnumbered children under the age of 5. And we expect that there's going to be over 22% of the world's population will be older than 60 by 2050. And so since, aging is the biggest risk factor, we expect that this problem of dementia is going to be growing exponentially. To start with, I think it's important to understand what the word dementia actually means. When we think of treating people, we provide targeted therapies, right? And so, think of all the illnesses that you have. Somebody tries to figure out what you have and then brings you an appropriate medication for that illness. With dementia, this is a little tricky. So dementia is actually better used for detection, So it means that somebody has cognitive and behavioral symptoms that interfere with their usual work, social activities, and it's a decline from a previous level of functioning. It cannot be explained by delirium, like short-lived confusion or a major psychiatric disorder. It includes cognitive impairment that can be detected and diagnosed based on history and objective cognitive assessment. Usually involves at least 2 different cognitive domains. So memory, executive, cannot reason or concentrate or has poor judgment, impaired visual spatial, so can't process information properly, difficulty navigating, impaired language, or changes in personality. But it actually isn't a diagnosis of anything. As physicians, we detect dementia. As patients or caregivers, you detect a change in function. And then, through our assessments, we can say if it's significant enough. And, functionally, you tell us whether it's significant enough to be called dementia, but it actually doesn't say what the cause is. And, I think it's really important to highlight that dementia is not equivalent to Alzheimer's disease. This is causing a lot of problems for people. In the past, people who had dementia were given a diagnosis of Alzheimer's disease. So we have a lot of patients in our clinics who say, I have I can't remember where I parked my car. I'm, forgetting things. And I have a number of family members with Alzheimer's disease. But then when you take the history, you realize that actually very few of them probably had Alzheimer's disease. And, maybe some of them had Parkinson's disease, dementia, or had vascular disease, dementia. So many different causes. And so it is important to try to be precise about, what the cause is. And really, dementia is an umbrella term that includes many different causes. And of course, it includes Alzheimer's disease, but it includes, things like primary progressive aphasia or frontotemporal dementia or Lewy body disease. It also includes things that aren't even considered neurodegenerative. So multiple sclerosis can cause dementia, brain trauma can cause dementia, infection, metabolic disorders, autoimmune diseases. So many things can cause dementia. And the reason that you want to be precise is that the causes are vastly different. And so when we look at the brain banks, and we often see that only 40% of patients who were thought to have a neurodegenerative disease have Alzheimer's. And so the rest, the 60%, had something else. And so if you had a treatment that was targeting the abnormalities of Alzheimer's, well, you wouldn't want to give it to the other people because it might not actually, they don't have Alzheimer's, might not help them. It might only give them side effects. So it is really important to make an accurate diagnosis. The other thing that I think is really important to understand is that when, a lot of patients who come to us say, I have these problems, but, my doctor told me I was aging, or isn't it just old age? So it is true that with advanced age, cognition there can be a decline. It's actually not that significant. Some cognitive domains decline more than others, but overall, there is an effect of age, and mostly it's in very advanced stages of age, but it isn't that significant. And it is not at the level of what we see in mild cognitive impairment or dementia when it's due to Alzheimer's disease. So although people will say, well, I have some more word finding difficulty, I wasn't like that when I was older, when I was younger, I'm having some trouble remembering, where I parked my car, or that's okay. But to have significant memory problems or concentration problems or language problems, that is not aging. That is a neurodegenerative disease. Part of the reason that, we understand that now is that we know that these abnormal proteins that are building up in your brain actually are starting 20 to 30 years before you show any signs of disease. So long before you come to our clinic and say, I, can't remember something, I'm having trouble. If we find that if there's Alzheimer's disease there, for example, well, 30 years ago, there started to be changes in your brain. And for all this time, your brain was able to compensate to these changes. So there was some amyloid changes, there were some tau changes. These are abnormal proteins that are going on. There's some shrinkage of the brain that is in excess of age. All that stuff was going on, and you didn't notice because your brain had compensatory mechanisms. But, eventually, when we get better treatments, we're going to hopefully be able to intervene at those times, right? In those 20 to 30 years, so that actually you never get to that time point zero where you start to, your illness becomes apparent to you and other people. And we know that all these changes that are happening, we can detect some of them with markers, and so even when people are asymptomatic, there's already lots of stuff happening in the brain. And we don't do screening now. So when you think of cancer, people do screen, right? Like people go get colonoscopies, they get PSA for the prostate, women get mammograms. All these tests are done because we have good interventions. So if you detect somebody at early stages, you give them an intervention, you intervene, and you can change the course of the disease. Well, we will hopefully get to that point in time because we do have many years where we could possibly intervene so that people don't even develop a mild cognitive impairment. They can, stop their disease dead in its tracks before it actually damages the brain so much that your compensatory mechanisms are overwhelmed and you show signs of mild cognitive impairment. And we, in 2011, ended up with new criteria. So there are strict criteria for how we make diagnoses of Alzheimer's disease now. And we try to separate out between the diagnosis of an Alzheimer's dementia versus the pathological process, the abnormal proteins building up in your brain that come out as dementia, that come out as Alzheimer's disease. The other thing that's very important is that classically, people thought of Alzheimer's disease as a memory disease. So, people would present with, I'm forgetting where I parked my car, forgetting people's names, forgetting names of objects. I forgot what I had for breakfast. And people thought, yeah, that could be Alzheimer's disease. But what was realized is that there are many other ways that Alzheimer's disease can present. So some people can present only with a language problem. Others only with a visual processing problem. Others, it could be just executive, like concentration and judgment. And others, it can be motor syndrome that includes language and movement. So there's many different ways it can present. We sometimes call Alzheimer's the great mimicker. It can show up in different ways, and used to be very difficult to make that diagnosis, but we're getting a little better now. These are the pathologies of Alzheimer's. So when we talk about Alzheimer's disease, we are talking about a brain that has amyloid plaques and neurofibrillary tangles. And the amyloid plaques are made of amyloid and the neurofibrillary tangles are made of tau. The reason that's important is because that's the treatments that are available. Those are the treatments that we have either, accepted in terms of proven, FDA approved, maybe Health Canada approved, and those that are in the pipeline. The vast majority of the treatments that have been tried or are being tried currently are attacking one of these two proteins. It's important to realize that before you get dementia, a person gets mild cognitive impairment. So this is a person who is concerned about a change in their cognitive function. That change is actually detectable. We can measure it with our cognitive testing, and the person is still independent. They are still very functional. Some people are actually even working, but if not working, they're managing their houses, their homes, they're managing their life, they're traveling, they're doing all kinds of things. They are functionally quite able and, or functionally independent. And so that means they are not demented. It's also important to realize that for many years now, over 2 decades, we have the capacity to detect Alzheimer's disease while a person is alive. I think some people still believe that you have to die to detect Alzheimer's disease, but that is not correct. We have very good measures for detecting Alzheimer's disease pathology. We can do a lumbar puncture, we can do PET scans, so we can detect the abnormal pathology in the brain, and not by taking out a piece of the brain, because obviously we could do it that way, but we don't want to do that. But we can measure, from a cerebrospinal fluid or lumbar puncture or spinal tap, we can measure like the amyloid and the tau and tell you yes or no, you have Alzheimer's disease. We can do a PET scan that will tag amyloid and tell us, yes, you have amyloid in the brain. You can also tag tau and say you have tau in the brain. So these tests are available, and they're actually quite good for giving us the answer of yes or no, a person has Alzheimer's disease. Most clinical trials today that are for disease-modifying medications, actually all clinical trials for disease-modifying medications require a patient to be biomarker-proven Alzheimer's disease. Wasn't that long ago that we actually ended up enrolling people who didn't have Alzheimer's disease, and they were given a drug that was for Alzheimer's. So, in cancer, that would be the equivalent of, a person having lung cancer and being given, colon cancer medication. Well, they probably would have been sued. But here, this used to happen. But for the last decade, it's most trials require that the patient have proven Alzheimer's. And now let's talk about treatment. When we think about treatment, there are treatment at early stages and late stages, and we can target treatments for cognitive function as well as behavioral psychological symptoms. So when we think of disease-modifying treatment, so let me explain. Disease-modifying is, what people think about when they get cancer, right? Disease modification in cancer means that you change the course of the disease. You live longer because of the treatment. I see somebody's hand is raised. Let's see. I don't know.
Dr. T, I've asked Brian. He's going to type his question in the Q&A.
Oh, perfect. Okay. Sorry, let me just go back. Maybe I can go on and then get it later. So yes, when we think about disease modifying for early stages of disease, that's when you can do the most modification, is that you would be able to change the course of the illness. So like in cancer, you get cancer and we get a medication, and the medication can cure us of the cancer, or, as happens in many cases, it prolongs our life. It can reduce the cancer size, it can eliminate it for a few years. So it actually causes a change in the course of the illness. So that's what we want. And that's what some of the medications that we currently are getting, but in early, at the early stage, are what we call disease modifying. And this diagram is for you to understand that there's many ways for these medications to work to eventually change the course of the illness. And so we have different targets, and there's lots of work being done in this area. We'll talk about where we are in terms of today, but this is a very active field. Right now, these are the one group of medications are targeting amyloid. These are all the different strategies targeting amyloid. Then there's another group that target tau. There's drugs that target lipids and neurotransmitters and neurogenesis, so the actual growth of cells, inflammation, cell death, metabolism, growth factors. This is a huge, huge problem, and lots of people are investing large amounts of energy and money to try to stop the disease, to change the course of the disease. This was in 2021. This was the Alzheimer's drug development pipeline, and all these little figures here are different strategies that people are using at different phases of the let's say the pipeline for drug development. And all this to say is that there's a lot of interest, there's a lot of research, and we remain optimistic that things will explode in this area in terms of being able to hit a few home runs. This is just to show you the different drugs that have been aimed at tau. The aducanumab was the first one to get FDA approval, but required a secondary trial, which is ongoing. The Roche drug did not make it, even though it had the same target. It didn't pass the goal line. Lecanemab has FDA approval, is being offered in the US and is under Health Canada review. A few of the other ones still being investigated. Donanemab, again, another one, has FDA approval in the United States, will undergo Health Canada approval. So there's a lot of optimism to, for patients, I think, these days. Tau monoclonal, so this is the other bad protein. A number of agents that are, in a more advanced stage of trial. And so hopefully we'll see how they do in the next year or two. And why is it important to be able to detect Alzheimer's disease now, especially at the early stages, is because there actually are these 3 drugs that, have pretty good evidence that they can change the course of the disease. Now, you may ask, well, are these miracle cures? Are they able to really stop the disease? No, they are not the miracle cures we are hoping for. But if you look at a lot of treatments that people have right now for other diseases, like think of Crohn's disease, think of, many inflammatory conditions like arthritis, lupus, we can slow down the disease. We can, create an environment basically for the patient to have less progression of their disease, less relapses. Well, that's where we are still. We're at a very early stages of being able to change the course of the disease. And this is just to show you, this is the one that came out recently. The important thing is that these drugs, including this last one, are really only being are really going to be available for people in early stages of disease. This last drug actually tested people in earlier stage and later stage and showed that you did much better if you were in the earlier stage of the disease. Of course, you might have heard of some controversy. Some of it is related to, how much slowing is there? Does it, what does it mean to slow the disease? And yes, for sure, like we've said, these are not miracle cures. And we would hope people continue and we do better, right? With each iteration, we get better at doing this, at stopping the disease, at slowing down the disease. So the tests that we use are, we look at the amount of PET amyloid in the brain. So this is a test that, basically we scan the brain and see if we could remove the amyloid. We look at different types of scales. So we ask a bunch of questions to the patient as well as their informant and see, if you're on the drug, are you better than if you're not on the drug? So these are the kinds of things. And, those are the endpoints and they were met. And so that's why the drugs passed, got approved. The issue is that these are very expensive drugs. And so how is our system going to be able to withstand that? It's, still a work in progress. This is to show you like the differences, right? Like you can see people like on the, let's say, you look at the far left, you can see the yellow line, the blue line, the drug is the yellow line, the blue line is the placebo, no drug. And you can see the kinds of differences over 18 months. Now, some of the differences are very large. If you look at that, center graph, you can say, oh, look at that. That blue line is really different from that yellow line. I want to be the yellow line because this graph is about amyloid in the brain. And so, yes, this drug actually removed a lot of the amyloid in the brain, which we think is a good thing. But when you look at all the other graphs around it, you can see that the yellow and the blue line are not so significantly different, right? They're not as big a difference as that nice center graph there. So that's the issue. That's some of the controversy, is how much better are you? And overall, we think that, for a lot of these drugs, people are getting 4 to 9 months extra in the mild cognitive impairment range, which, you might say, well, that's not a lot, but, the difference between mild cognitive impairment and dementia is being dependent, right? When you have mild cognitive impairment, you are independent. And when you have dementia, you are dependent. And so, how much does it mean to be able to go, see a grandchild's wedding and be, fully functional? How much does it mean to be able to be, participate more fully in activities for an extra 6 to 9 months, mostly it's 3 to 9 months, depending on what the scales were. Well, I think most of us would say, yeah, well, if you give me an extra 6 months, let's say on average, I would take it. Some people would say, well, you know what? If I have to take a drug every month, I don't want to. That's a personal choice. And, that's where we're at with these drugs. One thing I like to highlight is that, unfortunately, we're still at a point where some of our endpoints, these drug trials, they're based on these questionnaires. And one of the questionnaires is just, well, how's the patient's memory? How are they, how much are they able to do around the house? How much of their hobbies? And, and so this is not a science, these questions, because we all know, well, sometimes you have good days and bad days. And, the people answering the questions can also have good days and bad days. So I think, we're also moving towards having better, what we call endpoints, so that we could really judge how much better we are with a medication versus not. This is just to show you that this other drug trial, which is donanemab, similar, differences between the drug and the placebo. And again, showing that when you look at the drug's ability to get the bad protein out of the brain, that's where you actually see that it does do a good job. And what that will translate to, well, we don't know, but we remain optimistic that these trials were over 18 months, right? And when people think of Alzheimer's disease, it's a disease of 10 to 20 years. So maybe they will get more benefit if you look over the long term. But I think it's important to remember that most of the clinical trials with these disease-modifying agents target early stage disease. There's even some trials now where the people have no symptoms at all. We know that if you have that APOE4 allele, which is that risk factor gene, okay, that you are at higher risk of having amyloid in the brain. And so if you have that APOE4, no symptoms, and you have amyloid, there are clinical trials for that. Sometimes there are, research studies and people do amyloid tests. And again, they can see that they can be in these trials. But always, you have to be in very early stages. And one thing to remember is, one of these drugs is under Health Canada review right now. And the outcome of the Health Canada review will really try to reflect the inclusion criteria of the trials. So the drug will not be for everybody. The drug will only be for people who look very much like the patients in these clinical trials. That means they have to be either at the mild cognitive impairment range or very mild Alzheimer's disease dementia. So early stage dementia. They have to be functional, very functional. They have to have only a certain amount of beta amyloid and tau in the brain. And so it's important to remember that, because sometimes people think, oh, as soon as the drug comes out, I'm going to be able to get it. And I'll say, a lot of patients will not qualify. There were a lot of exclusion criterias, and now there's going to be even more, because I'm going to go over some of the side effects of these drugs. And one of the issues is that, there were some side effects that were seen more frequently in certain types of patients, and those patients will likely be excluded. Also, some of the controversy that people talked about was this, what we call this accelerated approval. So the drug trials got approved because of the ability to remove this amyloid from the brain. Told you there's 2 bad proteins in the brain that cause Alzheimer's, that are associated with Alzheimer's, and the drugs were able to remove that bad protein. Now, that isn't the same as saying, oh, the drug showed that it was so much better if you were on it, like clinically better, right? And so there was some controversy about this, and people jumped up and down, and there was a lot of upset about this. And, it's important to note that, as a field, there's been disagreement about this. But one of the things that I think is important to remember is that, cancer has come a long way, and they've done very well. There are a lot of treatments available, a lot of good treatments that can prolong life, that can, even curative treatments. And they are the disease that has the most of these accelerated approvals. And so because of this, there has been a lot of activity in that area. And, and I'm optimistic that getting accelerated approval will help our field get more interest, and also help us learn more about, what works, what doesn't work. But mostly, this will allow more people to come into our area and start working on this problem. So far, there's been only 290 accelerated approvals as of December 2022. Most are cancer. There were a few in HIV, and there were a few in multiple sclerosis. And that's really one of the areas where we've also been able to do a lot of, good work with respect to disease modification. And now we have 2 in Alzheimer's disease. But these drugs are not without side effects. The most common side effect is something called ARIA, amyloid-related imaging abnormalities, which we think is because you can pull that amyloid out of the brain. And so this is actually something that you see on an MRI. A person could be completely normal, but when you get these drugs, you have to have MRIs routinely, and you can see all this white fluffy stuff should not be there. And so a lot of times patients, like, this is basically swelling in the brain. We call it vasogenic edema. And so I think, part of the issue is, how are we going to follow all these people who get on this? What do we do when people are on this? Sometimes people can also have bleeds. So you see all these little all these little black things shouldn't be there. And so that is a concern for us. Obviously, the big concern is actually how we're going to follow people who get onto these drugs and need to have routine MRIs. A lot of times these hemorrhages are, inconsequential because the patient doesn't even know about them. But, you would still have to follow somebody because having blood in your brain is not a good thing. So these medications, however, we feel that they are, making a dent, in this disease, and, we're optimistic about them. Still, in terms of a system perspective, it's not going to be trivial to get them to patients. And this is just to show that sometimes all this swelling, doesn't have any other effect, except sometimes it does have a little bit of microhemorrhage in it. And so that obviously would need to be followed. The problem with the ARIA is that it's highest in these ApoE4 carriers. And so what's going to happen probably is that there's going to have to be some monitoring about that. And maybe patients with ApoE4 may not be able to get onto the drug. So it's not going to be trivial to be able to get these drugs to the patients. There's going to be a lot of things that we have to consider. So what about other things, right? Like those are the experimental treatments that we hope we have at hand. What is currently available? Well, right now we don't have anything that is what we call disease modifying that could cure or delay. We always stress that we need to treat other medical conditions that can happen at the same time as a person who gets, dementia or Alzheimer's disease. So if they have infections or Parkinsonian-like symptoms or seizures or pain, and we review all their medications. In Alzheimer's disease, we actually have these medications called acetylcholinesterase inhibitors. Donepezil is the most common one, but there's other ones too. And these are not disease modifying, but patients do feel that they help them. And we do have good evidence for, loss of cholinergic neurons in the brain. And so this medication helps to increase your acetylcholine and people get some benefit. Oops, sorry. And, over the years, there's been many studies, and I think we have pretty good evidence that they do something. They don't change the course of the disease, but for many people, helping your memory goes a long way towards improving quality of life. And so we routinely give these medications to people. We obviously treat other symptoms that can also affect your cognition. We know that depression is very, very common. And I think it's been increasingly recognized that people can start their disease with a depression, like a late life depression that happens, in somebody who's over the age of 60, 65, who's never been, had depression before, or they had, depression in the past can be a risk factor. So we know it's important to treat depression. And how do we treat it? We treat it with, the usual medications that we treat depression, even if it's a major depression disorder. We use things like sertraline or citalopram. We use duloxetine, mirtazapine. There's so many. Depression is so common in our society. We have many different medications that we can use for depression. It's also important to remember that dementia risk is reducible. Is that it's not just, there's nothing we can do, or it's only in, because we have a family history or something. No, we have a lot of evidence that there are things you can do to change the course of your disease if you have it, or if you don't have it, to decrease the chance of getting it. So diabetes increases risk of dementia. Smoking increases the risk. High blood pressure in midlife can increase your risk of vascular dementia. Lower education increases risk. Higher education lowers risk. Depression and obesity increase risk. Physical activity, cognitive stimulation decrease risk. And so in 2020, there were actually, this large report that showed that these 12 risk factors increased your risk of dementia. Now, this included things like physical inactivity, smoking, excessive alcohol consumption, air pollution, head injury, social isolation, obesity, lower education, high blood pressure, diabetes, depression, and hearing impairment. You may think, well, some of those things I could do something about. Some of those things I can't do something about because some things happened a long time ago, or some things are harder to control. But I always tell people, when you look at this list, think of the things that you actually can do. People can quit smoking. People can reduce their alcohol intake. The new guidelines are really that people should have less than 2 alcoholic beverages per week, Many people have way more than that. We cannot change the education we got when we were young, but we can continue to educate ourselves. And we know that that can be useful for slowing down disease. So it's important to think that there are modifiable risk factors for dementia. There's lots of evidence that vigorous activity, physical activity, can slow down this disease. This is a study done in 3,050 twins that found that moderate, vigorous physical activity was the only thing that differentiated those with cognitive impairment or not after 25 years of follow-up. And so, this was independent of all those other risk factors, that midlife vigorous physical activity resulted in better cognition in old age. Lots of evidence over and over again that physical and mental activity can change the time that people get dementia and even allow it to be slowed down. There's a large study in the world called FINGERS, Worldwide FINGERS, and Canada's involved in this, but it's all over the world now, showing, again, reproducible results that having, cognitive stimulation, having physical activity is good for the brain. And, in this one, it also included like having a good diet. So, low in fat, high in vegetables and fruits, physical exercise, making sure that you had social activity, cognitive activity was actually useful for slowing down the disease or preventing the onset, delaying the onset. Evidence, even if you have Alzheimer's disease, you can slow it down by doing physical activity. Again, cognitive reserve, not just about the education when you were young, but that even what you did throughout your life in terms of a challenging job, as well as, what you do in later life, can give you that cognitive reserve. And that cognitive reserve, even if you have disease in the brain, will help you have a slower progression of disease. So it's really important to remember that. And then obviously treating all those other things that we can treat. So if, I said Alzheimer's disease can present with speech problems. So, speech therapy can help slow it down. Occupational therapy for visual spatial processing problems, social activities. What about in advanced Alzheimer's disease? So I've already said the disease modifying treatments that are on the horizon will not be available at this time for people with advanced disease. And, advanced Alzheimer's disease, or when you have Alzheimer's dementia, means you're actually dependent for some or all of the basic activities. And what, in addition to all the cognitive and sometimes even motor issues that people can have, there can be also some neuropsychiatric symptoms. So we can give acetylcholinesterase inhibitors to people in advanced disease. It used to be we only gave it to people in the earlier stages, but now we keep people in advanced diseases on these medications if they can tolerate them. We give memantine. It's this other medication, completely different mechanism of action, but it is also approved for people in advanced disease. And there is some evidence that it does, provide some benefit. I would say not nearly the same as the other medication I talked about, acetylcholinesterase inhibitors, but overall, the study showed some benefit. And then there's the behavior and psychological symptoms of dementia that happen in more advanced disease that are really a heterogeneous group of symptoms that can include verbal, vocal, or motor agitation, and that really need treatment and can impact quality of life, as well as, well-being. And there could be a range. There can be psychosis, agitation, depression, irritability, aberrant motor behavior, sleep disturbance, eating changes. And the thing is, these are really, really common. 80 to 90% of patients develop at least one of these during the course of their dementia. And it's, the number one reason patients end up in long-term care. And many patients in long-term care have these. And, when we think of disease-modifying treatments, when we think of treating patients, this is actually, very, very disease-modifying, because when patients have these behavioral issues and they don't get adequate treatment, or we can't control it, this really does change the course of their illness, because many of the patients end up in long-term care. And so it's always important to make sure that it's not something else that's going on, like a urinary tract infection, or, they had a fall or something. And that, it is really the progression of their disease. What does it cause? Caregiver stress, increased emergency room visits, prolonged hospitalization, increased use of medications, long-term care, increased financial costs, as well as decreased quality of life. When we try to treat these behaviors, a lot of times we have to do a lot of education with families. We focus on big picture health and well-being, not the actual problem behavior, if we can. We capitalize on remaining abilities and strengths, try to create, enabling environments, distracting tasks, communicate slowly, clearly, use verbal cues. So there's, ways of treating these behavioral symptoms that are not really always related to pharmacology. We actually try to avoid giving medications as much as possible, but that there are things that we can do to really change the course of these, and not necessarily be medicating patients. But we spend a lot of time evaluating these patients and ask the family members to also do a lot of evaluation, and look for, are there, the basic needs met? Is the person just hungry or fatigued? And this is why this is coming out. Is the person just, sad or anxious, and, because they can't express themselves, that is coming out this way. So it's really important to try to get a lay of the land and see if there's anything that we could modify to help the person, feel better. We, of course, need to treat agitation. We can't, if the non-pharmacological doesn't work, we have to move to the pharmacological after we've figured out. And so we look for all the causes, we're cautious, we, partner with the families, and we only treat severe symptoms, and we always use the lowest dose for medications and for the shortest time. Of course, we do all the behavioral interventions we can, because like I said, when we think of disease modifying, treating these behaviors is really disease modifying, because it can change the outcome for this patient. And then if none of our non-pharmacological interventions work, we use the pharmacological interventions. It's important to note that there actually are no approved medications for agitation and psychosis in patients who have dementia. We use a range of different medications. And so if somebody has family members, they might recognize some of these. We always try, we start with the ones that are kind of like the most benign, and then sometimes move to the ones that, have the most side effects. But this is why we try to avoid them as much as possible, because there actually is a black box warning on antipsychotics, that they increase mortality in elderly patients with dementia. We use antidepressants, often, all different kinds, and there's some evidence that they can work as well, but they don't always work. And so we do sometimes have to use more, I guess, medications that, let's say, would have more side effects, like things like risperidone or Haldol. I have to say I've never had to use Haldol, so I'm very happy about that. And these are just other medications that people try. We sometimes use memantine, which I've said is indicated for people who are in the advanced stage of dementia, but we also have a little bit of evidence that it is good for agitation. We don't take people off of those acetylcholinesterase inhibitors, and we actually think that there may be some benefit to keeping people on that because they help people pay more attention and be more alert, and we think that actually can be good for helping with agitation. So we monitor, assess regularly, try to get people off these medications as much as we can, and oftentimes we try to take people off, and if they need to go back on, that's, we know, but, sometimes we can take patients off of these medications without worsening the symptoms. So to summarize, it's important that accurate diagnosis is actually the first step to treatment. We really think, I've focused mostly on the Alzheimer's disease treatments, but all of the causes of dementia, of cognitive impairment, you have to make the diagnosis. And then, you have to figure out what stage they are of the disease. And there are treatments, now we have some treatment options for people in early stages that are disease modifying in terms of changing the pathology, the buildup, and so hopefully having clinical benefit. But we also have disease modifying in later stages of disease, even if they are of a different, I would say, of a different nature. Lots of evidence for lifestyle modifications. And it's important to remember that, Alzheimer's and related dementias, this is an active area of research. And I think the last few wins, although not, home runs, I think, give us much room for optimism. And thank you. And I see that there are questions. Maybe I'll back to
Dr. Targalia. I could help with the Q&A if you'd like. I could read them out, or would you like to navigate that?
Sure. I mean, yeah, you can read them out.
Okay, perfect. We have lots of great questions. And please note, anybody that hasn't used the Q&A yet, just pop open that Q&A box and type your question in, and we'll get started with this. So the first question is regarding the causes and the etiology of dementia, Alzheimer's. Are there any scientific evidences to link the sugar consumption to dementia, as we hear now that dementia is the diabetes of the brain?
Yeah, that's a great question. So there's actually two parts, two responses. In terms of diabetes, of Alzheimer's being the diabetes of the brain, that is a theory. So we don't necessarily have evidence for that, but it is one theory that there may be some metabolic derangement that could in some way contribute to this pathology of Alzheimer's disease. In terms of sugar, though, one thing to remember is that, if an unhealthy lifestyle, which includes a lot of sugar, let's say, can damage the blood vessels of your brain and give you diabetes, actual diabetes, and that will give you vascular disease. So vascular disease is a disease of the blood vessels. If you have it in your heart, you have chest pain, and you get some people get stents or they have coronary bypasses. But in the brain, it's actually a silent killer of brain cells because, diabetes hurts the blood vessels of the brain. When a blood vessel in the brain is hurt or damaged in any way, whether it's from cholesterol or high blood pressure or diabetes, the brain around that blood vessel gets damaged or dies. And the problem is that you actually don't know about it. It doesn't give you, like, if you have a massive stroke, you'll know about it. But a lot of times it's just small. It's very, 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 very small. It's not even a mini stroke. It's like a miniature stroke, one blood vessel at a time. And you got millions of blood vessels, it's true. But you could imagine that if over the years, your unhealthy lifestyle is causing damage to many, many blood vessels, you're going to end up with what we call vascular disease dementia. So it could be associated with Alzheimer's because vascular disease dementia seems to make Alzheimer's more likely. But it could be that even without having vascular disease, without the Alzheimer's disease, you could still end up with vascular disease dementia. And so we always urge people to have a healthy diet. The Mediterranean diet is the one that is most well known. And that's a diet that is high in vegetables, fruits, and low in saturated fats. I hope that answers that.
Thank you. The next question is, are these tests in Canada? Doctors don't seem to know about them.
Yeah, that's a great question. So they are and they aren't. So the lumbar puncture, the fluid, the lumbar puncture is done, and a lumbar puncture is a spinal tap. It's done where people get epidurals. A needle is put in and the fluid comes out, and we have to send it away to get tested. That test is actually not routinely done in Canada. There's now one lab doing it in Vancouver. We used to send it to the United States if you lived in Ontario. But in 2019, the government decided that they didn't want to cover the cost of that test. And so OHIP stopped covering this Alzheimer's test. And so we had to stop it. Now, in the last few months, we have actually been able to secure some PET amyloid scans. So PET scans they're a kind of scan, looks like a little bit like a CT scan, a big donut. And what happens is they inject amyloid in your arm, a tag for amyloid. It goes through your body, and if it goes through your brain, and if it finds amyloid in the brain, then when we take the picture, the brain would light up. And so we've started doing that in just only since February. And we hope to continue that. And, we're going to have to figure out how to get people through there, right? Like through these tests, because it's a super expensive test. And there's hundreds and hundreds of thousands of people. So it's not going to be everybody that can get that test. That doesn't even make sense for that. So this is an active area. We have to find a systems approach to dealing with disease modifying treatments. And, unfortunately, there was an assessment done of Canada a few years ago. And what the result was that actually Canada was not ready for a disease modifying treatment, even if it came. Now, that report came out maybe 3 or 4 years ago. So before there was a disease modifying treatment, and said, yeah, you guys aren't ready. And now there's going to be one available maybe, because it's under Health Canada review. And we have to figure out, how are we going to get ready? And it's not so easy to figure that out.
All right. The next question is, you mentioned risk factors for Alzheimer's, but do we know anything new about what triggers the onset of Alzheimer's?
No, we don't. We don't know what triggers why some people get Alzheimer's, other people don't, why some people get Alzheimer's and others get Parkinson's disease or Lewy body disease or frontotemporal dementia. So no, we don't understand. We do know that there are things that seem to be protective, like exercise, good level of cognitive function, like having either high education or challenging jobs. But we don't actually know why some people get it and some people don't. Age is the biggest risk factor, but I have many patients are, not even 60 years old and have Alzheimer's disease full blown. they lived a healthy life, highly educated, exercised. I have no idea why. And they don't have any genetic factor. So, you know, do I think that someday we'll figure out what gene environment interaction? Yeah, for sure. But right now, there's still a lot of unknown.
Thank you. If my grandfather and my father have been diagnosed with Alzheimer's, can I be tested? I am 57 and would like to know.
Yeah, so having a grandfather and a father who have had Alzheimer's disease, actually your risk is not that much higher if those people developed Alzheimer's disease after the age of 65. So, you know, when you, like I said, age is the biggest risk factor, right? So if you come from a family where you guys have all been fortunate enough to live to be like 80, 85, 90, 100, well, the chances that you have some people with late onset dementia due to Alzheimer's is going to be very, very high. And the person who's everybody in their family died of cancer at 50 is going to have no Alzheimer's disease in their family. It does not mean that they are at lower risk. So it's not just about the fact that you have your dad and your grandfather. The other thing is, sometimes it isn't Alzheimer's. There's a lot of people who got a diagnosis of Alzheimer's, but it actually turned out to be like vascular disease or some other type of degenerative disease. So we don't test people because they have that family history. Now, if you had, you know, 3 brothers and a sister, 2, you know, your 3 uncles and a parent, your grandparents had Alzheimer's, you know, like grandfather, let's say, and people on the grandfather's side, that's different. Right? In that case, we would say, yeah, you are probably at high risk. We should do genetic testing. That's a family history of Alzheimer's, where in every generation, there is many, many, many people with Alzheimer's.
Thank you. In terms of diagnosis, should everyone that is concerned about developing Alzheimer's get a lumbar puncture or a PET scan?
No, because the issue is that today, it's not, you will not be able to be given any disease modifying treatments unless you have at least mild cognitive impairment. So that's going to be the criteria for getting any testing done, is that a person have mild cognitive impairment. And then, you know, we'll have to see what other criteria gets put in place, but you have to have mild cognitive impairment at least, or early signs of Alzheimer's or early signs of dementia to get the testing.
Thank you. Oh, it just jumped. What is the doctor's view on TMS treatment for Alzheimer's?
So that I'm assuming that you're asking about transmagnetic stimulation. It's under research. You know, I mean, I think there's lots of different avenues that are being investigated, and transmagnetic stimulation is one of them.
Okay.
The evidence isn't out yet. It's still, you know, still being investigated.
The next question again is about those early ways to identify dementia markers before there are symptoms. Are there any simple tests available to people that are concerned?
Yeah, I mean, that's a great question. And we don't have anything right now. Like some people do online brain games and tests. And, you know, right now there isn't any of them that have any, you know, like high value in terms of screening for any of the neurodegenerative diseases. We are working towards having some blood tests. And so I hope the day is not that far off. I think I can, you know, maybe see it where you will go to your doctor and tell them, you know what, I don't think my memory is as good as it used to be. And once your doctor rules out things like sleep apnea and, you know, B12 deficiency and thyroid problems, they say, you know what, we're going to do a blood test. And if that blood test comes out as positive, then you will go for the confirmatory test of a lumbar puncture or a PET scan. And I think that's the way we're going to move to, we're going to move towards there. But we're not there yet. We don't have any blood tests right now that are approved for usage in clinical practice.
Thank you. The next question I think you've already answered about Alzheimer's or dementia and that genetic component. Here's the next. I'm not going to pronounce this right, so my apologies.
Yeah.
Thank you. Some patients had swelling in areas of the brain and hemorrhages. However, only 3 people died as a result of these abnormalities. What are your thoughts on these side effects? And is it a serious cause for concern, especially since it may be approved by the end of 2023?
Yeah, I think that's a great question. The incidence of having a brain swelling and these microhemorrhages that were asymptomatic, or not, I would say not benign, but having very low symptoms like maybe a headache or not feeling quite right, was not uncommon. It was like 25 to 35%. But the number of people who actually died is very, 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 very low. Now, it was not zero. So, in one trial, it was, I think, 3 people. So it was low. I think that the issue is that, because there's so many people affected, that, we have to be careful, because even if it's only 3 amongst a few thousand patients, you're saying, yeah, well, that's low. But when you have hundreds of thousands of people who could end up on the drug, will it still be low? And that's what I'm saying. I think they will put very strict criteria of who can get on the drug, because, you have to remember, although Alzheimer's disease, I think, is more feared than cancer these days, the people who will be getting this drug, who are going to be able to get the drug, right, are people who are in mild cognitive impairment or early stage of disease. And those people probably have a pretty good quality of life. So, you have to think, like, how much risk are they going to want to assume to get this disease modifying treatment? And that is a personal choice. So, I think we're going to have to follow people very closely. And, and so that's one of the issues that we're working through right now, is how we're going to get people to do routine MRIs to be able to catch anybody who looks like they're going to get themselves into trouble and stop the medication in time so that they don't die. So yeah, but as you say, it is a very, very low number that in some ways has been blown out of proportion. But I think because of the fact that people, were otherwise in good health and they died from a side effect of this medication. So that's, important to consider.
All right, thank you. The next 2 questions are kind of revisiting some of the information about memetine. I believe that you did answer this in the seminar, but does it help a patient with Alzheimer's? The other is giving a bit of a personal background on, in 2008, has been taking galantamine.
Galantamine, yeah.
Thank you. And when memetine was added in 2021, has begun to deteriorate much more. Help and suggestions.
Yeah, so mementine has some evidence that it helps, but it's not disease modifying. And it doesn't help the memory like the acetylcholinesterase inhibitors like galantamine or donepezil or rivastigmine. So it really is a different type of medication. And, there is some evidence that can help with, agitation also. But one thing to consider is, neither of those medications that you mentioned, memantine or the galantamine, are disease modifying. So the disease is progressive. I don't think it's related to the memantine, but I would just stop it and see if there's any side effect that, you're noticing. But no, I think I think honestly, this is more progression of the disease. But because these are not disease modifying medications, I always tell my patients, stop the medication, let's see what happens. If it's from side effects, they'll go away. And then, we'll revisit and reevaluate.
Thank you. I see that we are coming close to a close. How are you feeling about continuing on a few more questions?
Sure.
Okay, I'll try to point out maybe some that aren't so. Here's another medication one that might be relevant with the use of antipsychotics. Mom has been in long-term care for about 6 weeks and is taking risperidone, but we've noticed a complete decline. She is just sleeping almost all day and most days. Should the risperidone be removed?
Yeah, so it's very, very difficult to comment, right? Because I assume, just like myself, I only use risperidone when a patient really needs it. When people are agitated, they are actually at risk of causing harm to themselves and to others. And so that isn't a state that a person can remain in for very long. The problem with risperidone is it is sedating. So, it's kind of like this balancing act, which is getting enough benefits so people don't harm themselves while not putting the person to sleep, which is really bad also. So, I would discuss with the doctor to say, maybe easing off a little bit and see if we can get the benefit. You also have to remember that sometimes when these medications are started, people do get a lot more of the sedating effect that wears off over time. And to obviously to make sure that they're not like, having some kind of infection or something else. But it's always hard for us to comment when we're not there evaluating, we're not seeing what the behaviors actually are. Yeah, so I hope she gets better.
So a few of these kind of have the same theme, and it's how do we get the treatment? How do we get the diagnosis? What kind of path should we be self-advocating for? So do you have any advice when it comes to newly diagnosed or questioning the path of getting the appropriate assessments for diagnosis?
Yeah, so I'm going to say this is a call to arms. There are not enough physicians in Canada to see patients for this problem. There aren't enough cognitive neurologists. We are 10 in the province of Ontario. There aren't even enough geriatricians. There aren't enough primary memory care clinic doctors. There are not enough people to even see all the patients that need to be seen for this problem. So the system has to change. There are not enough tests. So, to get a lumbar puncture, well, a lot of the doctors don't even know how to do that. They haven't done it since medical school. You wouldn't want them to do it on you. So, problem. There aren't enough PET scanners in the province to be able to do a PET scan on everybody. So there's a system problem, and patients have to advocate for themselves. Family members are going to have to advocate for them. And it's really going to be upon the government to change the system drastically. We don't have enough MRIs. If anybody has tried to get an MRI recently, it can be up to a 1-year wait. Well, you can't get this treatment if you can't get an MRI routinely. I've just told you that you can have microhemorrhages in the brain, that you can have swelling of the brain. We don't have enough places to give infusions. And these drugs right now are monthly or bi-weekly infusions. There's a problem. And the problem is that our healthcare system was never designed as it is today for there to be a disease modifying medication for a disease like Alzheimer's disease, which is so prevalent. And so everybody's going to have to do something. There's no point in saying, well, this is how you're going to get it. You and thousands of other people are going to be in the same boat. So I don't know who's going to make it to the front of the line. It's a huge, huge problem. And everybody's got to get together and, write letters to their MPs, complain and not accept the situation. This is not right. This is based on nihilism that there was towards brain diseases in general, that if you got dementia, well, it's a disease of old age, so just be silent and quiet and try to die peacefully. But that's not it, right? These are not diseases of old age. I mean, they're diseases of old age, but this is not old age. These are diseases and they need treatment. And there are a lot of people in those age ranges where they're at the highest risk of these conditions. So we have to do something. The current situation is not going to handle this.
I thank you so much. That was so well worded and really addresses the systematic issues that we're dealing with right now. We're coming to a close. It's just after 7:45, and I can't thank you enough. This was informative and relatable, and I thank everybody in the audience for coming to join us with some great questions. Again, we leave you with this note of self-advocacy, connecting to those resources, and looking at both the pharmacological and non-pharmacological approaches to maintaining your well-being and your brain health. So Dr. Tarkatlia, sorry, I thank you so much for this presentation tonight.
Thank you. It was nice.
All right,
Everybody, and
everyone.
all the great questions. Thank you.
Thank you. Everyone have a great evening, and please, I'll work on the questions in the rest of the chat. If you'd like answers to some of those or the content will be available to review because we have recorded tonight's webinar. All right, everybody, that brings us to a close, and thank you so much for joining us this evening.
Bye.
Thank you.